We have a large AML cohort in Rotterdam of over 2,000 AML cases. And in those cases we asked the question, what are the mutations that are specifically associated with secondary AML, so clinically proven secondary AML. And so we came up with a signature of 9 mutations, so quite similar to the signature that Coleman Linsley published in 2015. So spliceosome mutations and also chromatin remodeling mutations. And in addition also RUNX1 mutations were strongly associated with secondary AML. So we use this signature to separate secondary type AML. So we use those mutations when present as an indicator for secondary type AML, and we compared those cases with the remaining de novo AML cases. And what we saw is that these are clinically different. So for instance, the blast count is lower generally. And so we think that these cases have a different etiology, and so I think we should look at AML as being 2 different diseases in a way, so de novo AML and secondary type AML. And then the TP53 mutant AML, which I was talking about earlier, is yet another separate entity within AML. If we now look at MRD in those cases, I think that the MRD, so the next generation sequencing based MRD, works beautifully in de novo AML. In secondary type AML it will be more challenging to do next generation sequencing based MRD detection, because you have many clonal hematopoiesis related mutations that persist but do not necessarily associate with relapse.